What was not clear is whether SGLT2 inhibitors might be a treatment in patients with existing heart failure. Furthermore, whether or not this class of agents could be useful in patients without diabetes. The DAPA trial randomized patients with heart failure and reduced ejection fraction to either dapagliflozin or placebo. These were typical heart failure patients with an ejection fraction below 40% and a modest elevation in BNP. The two main exclusion criteria were an eGFR less than 30 and a systolic blood pressure less than 95. Over 4,700 patients were enrolled and followed for an average of 18 months. They were very well treated with an ACE inhibitor or ARB and beta blocker use in approximately 95% of patients and an MRA in 71% of patients. The sacubitril valsartan use was a bit lower. The primary endpoint was a composite of a heart failure event or cardiovascular mortality. There was a 26% reduction in the primary composite endpoint. The number needed to treat to prevent one event over 18 months was 21. The individual composite endpoints were each reduced significantly. Importantly, there was a significant 18% reduction in cardiovascular mortality. Another important secondary endpoint was the reduction of symptoms using the Kansas City Cardiomyopathy Questionnaire. Patients in the DAPA group had fewer symptoms of heart failure. All-cause mortality was also significantly reduced. The treatment strategy was very well tolerated. Less than 5% of patients discontinued dapagliflozin, which was the same proportion of those taking placebo. A critically important result was that the benefit that was derived in the primary outcome was the same in patients with HFrEF and diabetes compared to patients with HFrEF without diabetes. Further pre-specified subgroup analysis was presented. Benefit was consistent across the age spectrum, in diabetics and non-diabetics, and background medication use. Specifically, whether or not the patient was on an ACE inhibitor or ARB, whether or not the patient was on a beta blocker, or whether or not the patient was on a mineralocorticoid receptor antagonist. Importantly, there were no adverse safety events. In summary, dapagliflozin versus placebo was associated with a reduction in cardiovascular death and heart failure events, as well as an improvement in symptoms. The benefit was consistent across various subgroups. There was no sign of adverse safety events. Dapagliflozin may signal a new approach in the treatment of patients with heart failure and reduced ejection fraction.